Hello, everybody. Welcome to today's Cardiovascular MR Journal Club. Today I'm hosting from Potsdam in Germany, and I welcome everybody here. I saw that lots of people well-known and also well-known to me have joined, so I'm very happy to have you here. So in these times, a lot is about COVID-19, so I thought it would be best to also have a special today on cardiac MR in times of COVID-19. So instead of going through papers today, because there are not that many papers out there to COVID-19, although there are some out there, there are even less papers on imaging, pretty much nothing on cardiac MR, but there are a couple of very important considerations for cardiac MR. And I hope this will be an interactive journal club so that I'm not only presenting, but also that we share maybe some experiences and some thoughts on how we deal with that global challenge that we have. So I hope everybody can see my screen. As usual, please mute yourself if you're not speaking. If you want to say something, just speak up, unmute yourself and speak up, or you're welcome to pose at any time, put a question into the chat box, and then we'll discuss that later. So today, as I said, it will be about cardiac MR in times of COVID-19. And let's first talk about a little bit about, oh, sorry, I didn't want to skip that. This is my disclosure. Important software development. Please, again, so whoever is not muted, please mute yourself. And I can also try to, just a second, I think now we're muted. So COVID-19 is a disease caused by a virus, and the virus is a SARS coronavirus variant that's pretty novel to humanity. It is similar to influenza, but the virus appears to be more contagious and also more deadly. So the mortality is higher, and we'll discuss the reasons for that in a second. COVID-19 is a substantial risk for patients with pre-existing chronic diseases, for elderly patients, and also immunosuppressed patients, and of course, simply because of the exposure, healthcare staff. So that is probably all known to you. It's also known that COVID-19 is a pandemic. Currently, we have 275 active cases. The total number of cases is more than 350,000 or 390,000 already, with 7,000 deaths. That's still, just to be real and have all the perspectives, that's still not a high death toll for pandemics or influenza pandemics. But this one appears to spread pretty aggressively across Europe. Currently, Italy has 64,000 cases and more than 6,000 deaths. And it started the same now in North America, and I think many of us are concerned about the United States. Maybe states probably will be the hardest hit of all the countries. And so we hope sincerely that there will be ways and measures that limit that damage. And of course, as we all have seen or are seeing in Europe here, especially in Italy and in Spain currently, it significantly affects social life. It was first so in China, and was also done like that in South Korea and Taiwan, where it was very efficient, and the social distancing, or as I would like to call it, physical distancing, is probably the only thing we can currently do to slow down the wave and to limit the risk of having the healthcare systems being over capacity. But in long term, it will also affect economy, and it currently affects, of course, healthcare. Compared to other pandemics, COVID-19 is still a small one, as I said. So compared to recent, even to pandemics during the last 100 years, there's still a lot, but these, we know these can be devastating, and certainly COVID-19 would be as devastating if we would not do something about it. So the virus, and this is important also for the imaging part, it enters the cells through the ACE2 receptor. That is prevalent in the lungs and the heart, but also in the kidneys and in other organs. but the heart is one of the tissues where it is expressed quite a lot. After an incubation period, the typical symptoms are sore throat, dry cough, fever, myalgia, and recently reported a loss of taste and smell. And the first symptom of severe disease is shortness of breath, and that's where sometimes then cardiac MR could play a role. And it leads to an extensive necrotic inflammation in the lungs with poor prognosis, but even early reports from China have indicated that maybe up to 20% of those patients may also have an acute myocardial injury that is not necessarily ischemic. So there is pretty much no real experience for that, but going to these early reports, we have this, there may be a cardiotropic activity of or prevalence of the receptor 2, and that's why CMR may play a significant role. So when it comes to myocardial injury, I caught myself I was looking at papers that I can't understand simply because they are written in Chinese and literally in Chinese. And so this is currently the data, or some of the data we have to deal with. So what we know from that so far is that we probably deal, when it comes to cardio or cardiovascular, with 4 major injuries. One is RV overload that is not specific to COVID or influenza for that matter, but can happen with any etiology for pulmonary hypertension that may lead to right ventricular overload, failure, and injury. Then we have acute myocardial injury, that's myocarditis, that's direct viral-induced inflammation. And then we have acute myocardial infarction that could be the etiology of acute myocardial injury. And then we have also an inadequate output in the context of sepsis that could lead to heart failure, despite a relatively normal or even high cardiac output. Simply the demand may be too high, and then secondary damage to the myocardium. So let's just focus on the 2 major, this is acute myocarditis and acute myocardial infarction. So because these may have acute therapeutic consequences. And this is where, of course, MR comes in. We can differentiate ischemic from non-ischemic myocardial injury with cardiac MR. And within the non-ischemic etiology, we can differentiate certain forms with some specificity, such as infiltrative disease and inflammatory disease. So that's where we may have a demand for cardiac MR studies in patients with suspected acute injury, because it would be important to know, is it ischemic? Then an acute revascularization may be very important. Or is it inflammatory? Then we would need aggressive heart failure therapy to reduce afterload and preload to reduce the injury in the myocardium. So we have updated Lake Louise criteria for cardiac MR in acute myocardial infarction. They, of course, are applicable to COVID patients. And due to reasons I come to in a minute, it is important to keep in mind that the criteria here.
Sì. Allora, io qui ho la release 5.9.
They are not using any contrast agents, so that is native T1 and T2. So let me just see, sorry. Can you please mute yourself if you're not muted? So because otherwise it's difficult for me to always unmute or mute people. If we look at this protocol or at the Lake Louise criteria, we can assess a patient without injecting contrast. This may be important because it would lead to shorter protocols, and it also would not need basically an interaction with the IV, which requires the technology just to be close to the patient and therefore increase their risk of acquiring the virus. So when we talk about safety, we have to first, of course, remind ourselves what are the infection pathways. And that is extremely important, because we have these people who go to whatever Bondi Beach or Clearwater Beach and have parties because they don't take that serious. On the other hand, we have people who are so panicky that they don't want to get even 2 meters next to other people because they think they will get the disease. So it is transmitted by droplets through contact, which get into contact with the endothelium, so with mouth, nose, and eyes. The transmission through droplets can also happen through contaminated surfaces. The transmission through aerosols is very unlikely. There has been a New England Journal paper that contained the phrase in their conclusion that aerosol transmission is plausible. But the paper clearly was not a clinical study and clearly used abnormal experimental setups to show that in theory there is an aerosolization is possible, for example, during an intubation. But all in all, it's very unlikely that someone can transmit the disease without coughing someone into their faces. Is it very difficult to transmit the disease to aerosol from all that we know so far. And I know, for example, from Italian colleagues who have been working in intensive care units now for weeks with intubated COVID patients. And despite all that, their regular mask, gown, gloves, protection equipment was good enough so that they did not get positive. They are still tested negative. So that's what we have to keep in mind when we talk about safety of MR. So therefore, the regular personal protective equipment, mask, gown, and gloves should cover the endothelial areas. The eyes, if you think about it, the eyes are not covered here. So people who wear glasses have less of a problem. Others may want to have a shield, a mask with a shield. Now, if we consider this and respect these, then we could think about the following rules: how to reduce the risk for the MRI staff, but basically provide the service our patients need. So one way to do that, and this is how we will proceed, or how we proceed at McGill currently, we only do urgent cases. So there is currently no room for elective cardiac MR cases. We use mask, gown, and gloves for patients and healthcare personnel, for both, and that should, with very, very high likelihood, avoid any droplet transmission. We use focused native CMR protocols where possible. Focused means not basically doing everything in the patient just to see, maybe we'll also do a flow here or an additional sequence there, but really have a very focused protocol. If it is about acute myocardial injury, then we basically need function and we need information on the tissue, on the acuity and the extent of myocardial injury. That's it. And then if we can, so if people have a reasonable native mapping sequence that they can use, then they should use it where possible. And as I said, in order to reduce the exposure of the staff to the patient, not being too close. And then afterwards, a careful surface cleaning. So after the scan. Now, for some of you, you may have experienced, so if we talk about tuberculosis patients and some others, there's a more extensive protocol that requires an extensive cleaning protocol for the surfaces, but also basically the cleaning of the air in the scanner room for at least 1, if not 2 or 3 hours. So this is a protocol that I don't think is required for COVID-19 patients. Having said that, it is of course different if a patient is intubated or is coughing and not does not, to whatever reason, have the personal protective equipment, for example, took his mask down and coughed into the scanner or whatever. So of course that is beyond this regular protocol. But in terms of the safety, from all what we know, if we use a mask, gown, and gloves and perform a surface cleaning, the likelihood of a transmission is extremely small. So there have been studies from China where they tracked patients and assessed the rooms before and after the patients were there or used washrooms. They could identify virus material on lots of surfaces, and you probably have also heard about this, stays for many hours, if not longer, on certain surfaces. That does not mean that this virus material is still infectious, but it still means that there's virus material, so we have to assume it may be infectious. But these studies have also shown that if there was a regular cleaning performed in these rooms, there was no virus material left that even came close to being infectious. Plus, the exhaust, so basically the airstream ways were free of any virus material. So we can assume that simply a patient, always assuming that they have their PPE on, will not basically contaminate the room. So additional measures in critical intubated patients would mean that the people would have to wear a more extensive mask. So the naming is different for these equipments, but in many it would be an N95 mask that has to be fitted to the face, so it's not this little paper mask, plus a face shield. That what I personally would also recommend in others if you don't wear glasses, and the extended cleaning protocol of the scanner and the scanner room. So these would be the rules that we have to respect when scanning COVID-19 patients. So here is a workflow, or let's say a clinical pathway that I wanted to present and maybe also discuss before I stop, and then we should have maybe those of you who feel comfortable sharing their experience, or of course any questions, and we can discuss that. So if you have a patient with suspected COVID-19 and the patient has clear clinical features of acute myocardial injury, that means symptoms like chest pain, shortness of breath that is not otherwise explained, arrhythmia, or if there's an ECG, an ST elevation, for example. There are recommendations from some societies to check every 48 hours troponin, and the same would be true for an electrocardiogram. So if by any of those there's a significant suspicion of acute myocardial injury, be it mild or obvious, then troponin should be performed, a marker for myocardial injury. And if that marker is high, if it's not, then you just keep on monitoring. But if the marker is high, that would simply mean, okay, we have clinical evidence and we have serological and ideally also electrical evidence for acute myocardial injury. So this may be either non-specific, like RV overload, or it may be acute myocardial infarctions or coronary event, or it may be an inflammatory event caused by the virus or the response to the virus. So these are three possible outcomes of or reasons. And of course, cardiac MR is the only modality that can identify them, all three of them, very clearly and specifically based on their pattern. So while a normal scan would make it very unlikely that there's extensive ischemic or non-ischemic injury, and then a follow-up can be done by echo. And only if in echo you see a deterioration of function, you would then probably have a good reason to repeat the MRI. if you have the other cases, acute MI, then depending on where you are, most of the centers currently would perform a PCI, so coronary intervention with acute revascularization. But there are proposals coming from China to not do that in order to reduce the risk for healthcare workers to be exposed. And in these cases, even thrombolysis comes back into play. And of course, if there is myocarditis, then you do not need to do that, but then you proceed with more non-specific heart failure therapy, like afterload reduction, preload reduction. And of course, some people may think that certain antiviral therapies could be applied, but we do not currently have any controlled or otherwise reasonably good data to support any of the therapies, be it hydroxychloroquine or be it azithromycin or vidarabine or any of those antiviral markers. We simply do not have the data yet. Some people may decide, I know that in Iran, for example, people are now already treated with hydroxychloroquine. But this is certainly a risky business because we know the outcome of COVID-19 in younger people, especially, is relatively good. So treating patients with that would probably be a fairly desperate attempt. And I can understand that people, if there's nothing else and they fight for the lives of their patients, that someone will start doing that. It's just we have to just keep in mind we do not have currently proper data to support that. But we can do something that where we know it works, and this is heart failure therapy. So if we know from myocarditis that non-specific therapy with afterload reduction or preload reduction or both helps reduce the strain on the heart, the end systolic stress and diastolic stress, and that is helpful in acute myocarditis, especially if it's severe. And we have to assume, given the fact that it goes through the ACE2 and ACE2 receptors, we have to assume that it could be a severe injury. Okay, so that was it from my end. If you have any questions, please tell them. And also, I would ask all those of you who have significant experience with MR, and I see that João Cavalcante is there. I see that Yuchi Han is there. I saw Deborah Kwan. I see Reza. I see Greg Hundley. So we have lots of people with experience with MR. So feel free to speak up and add to the discussion. And first of all, thank you for your attention. So if you have a question, just unmute yourself. There's one question. What are your thoughts regarding contaminated soil? So I'm not a virologist and I'm not an expert in that. I just find it relatively unlikely that a virus survive very long. It needs cells, and if you have a moist surface, of course, there's the theoretical option that a droplet can stay for a while on soil. And we also know that dogs can be infected. We know that it can be found on shoes, but we have so far no evidence that this would be a significant source of spreading the disease or infection.
Matthias, that was a great presentation. Thank you. This is Greg Hundley. I was just wondering, do you have the papers or data that you could circulate indicating the incidence of myocardial injury in the patients? That'd be wonderful.
Okay, thank you very much, Greg. So we will post the papers on the CMR Journal Club archive. Okay, and they can be downloaded from there.
Matthias, this is a great presentation. João Cavalcante here. Thanks for doing that and keep us entertained and informed about this field that is moving so quickly. I just wanted to make maybe a couple comments about I like the diagram that you have it there. I just wanted to obviously emphasize the importance that this transmissibility of this virus projects to us, and maybe subject that echo should be moving up front before even the CMR. We love CMR, but a quick, really limited echo should be able to tell us the information we need. I would probably put the echo right below when the troponin is elevated there. Is the ejection fraction normal or not? Do we have pericardial effusion? I would like to hear what the other participants here think about that, because is the information on the MRI going to be actionable or not? If it is an MI, obviously we need to even debate, do we need to intervene or not? What does everybody think about that?
So maybe I tell you, because we had the same discussion, I tell you why I ended up not putting it there, but I'm not claiming that I'm right. I just want to make everybody understand my thoughts. The echo, I would have, to me, two disadvantages. One is it is not very sensitive. We know that myocarditis can initially come, or in most of the cases, actually, in a otherwise relatively healthy population, it comes with normal LV function. So the echo may introduce a false safety here and miss points. And then the other, it is also not very specific. So if there is a wall motion abnormality, we also would still not know, is it acute MI or myocarditis? Of course, you could say, then you could do a cardiac MR, but there's still the sensitivity issue. That was one of the reasons. But I'm really happy to hear other discussion areas. So I see that there are now posts coming in, and I go with them in the order of appearance here. Just raise your hand in the chat window. So then from Michael Solano, post data recleaning, any consideration of putting an N95 mask on the patient. Again, please mute yourself. If you're not speaking, please mute yourself when you're not speaking. So the N95 mask probably on the patient would not provide additional protection, because the main point of wearing a mask for the patient is to avoid the spreading, and the mask, the N95 mask, does not have significantly more protection from the droplet ejected into the air. And so there's probably not much more, theoretically, yes, maybe a little bit more protection, but then there's also the logistical issues that N95 masks are typically much shorter in supply. Then from Graham Wright from Toronto, he also echoes the request for the references. I assume your algorithm does not include STEMI. They still go straight to primary PCI. Protocols are being developed for COVID screening of STEMI patients. Yes, we had actually the discussion also at McGill, but the cath lab, several cath lab doctors are highly concerned about STEMI patients, to have them go right to the cath lab if they are tested positive. They think in these cases one could consider thrombolysis. So we may enter a world where the dominance of PCI may be questioned in some patients, but I agree, in many centers it would still be exactly as you said, they go straight to the cath lab. So then there's a comment from Leandro Slipchuk. We're using POCUS at Montefiore. Can you briefly elaborate on what that is? What is POCUS?
Sure. Hi. Thanks. That was a great lecture. So we're trying to minimize the exposure to text. So trying to use a focus ultrasound that can be done without a full echo that is not needed, to try to decrease the exposure. And this can be done by the ED physicians as well, and then uploaded and read by the cardiologist.
Okay, great. Thank you very much. Can you otherwise comment on some of the key experiences you had in Montefiore?
Yes, I mean, we're just starting, to be honest. A week ago compared to now is a completely different thing. But we're trying to switch for the chest pain patients to use mostly CT instead of stress tests, to try to expose less people to the virus as well. So I'll have more information on that maybe in a couple of weeks.
Yeah. Okay. Yeah. Thank you. So it's already top of the hour. My promise always to the CMR Journal Club is to keep it short and do it in half an hour. I know that there are probably maybe more contributions and discussions. So there's one more I wanted to share from Paladinesh. Important to keep in mind not only potential benefit for patient, but also the downside for other patients and providing a busy service. Yes, that's of course, we always have to keep all the patients in mind. The fact that we live in a COVID world doesn't mean that there aren't other patients. So there are lots of ethical issues that may come up during the day. So in 2 weeks, we will have a follow-up. I will continue with COVID. At that time, we hopefully have some updates, maybe a better understanding of the myocardial injuries, and having some more discussions on the protocol. But thank you very much for listening, and thanks everybody for joining and for the valuable contributions. And we'll see each other in 2 weeks from now. And wish everybody who's in the front line all the best, and let's hang in there and get together through these difficult times. Bye-bye.